I would like to thank the organizers and Professor Kotsis for his kind invitation to participate once more in this meeting of the working group. So in the next minutes, I will talk about the combination-based strategy for cardiovascular disease prevention. And I would like to start showing you what is the recommendation of the European Society of Hypertension. How to start treatment? Our recommendations say that in the vast majority of patients, combination treatment with two drugs at low dose should be started. This is even for patients with low grade 1 cardiovascular risk, grade 1 hypertension and low cardiovascular risk, because in addition to lifestyle, the physician may select between low dose monotherapy or even low dose combination. Why is this selection? Because the blood pressure target is much more strict, also in patients at low risk. And if we want to achieve the blood pressure target, more than 20 millimeters of mercury of blood pressure reduction, in the majority of patients, we will need the use of combination therapy to start treatment. Only monotherapy is reserved for the very old or frailer patients or those subject with grade 1 hypertension with systolic blood pressure lower than 150, very close or more or closer to the target. This recommendation, even in low risk patient grade 1, is based on evidence. And you may see the data of the HOPE-3 trial, in which subjects with low or moderate cardiovascular risk were treated with a combination, low-dose combination of an ARB and hydrochlorothiazide. And you may see in the slide that for patients in grade 1 hypertension, it was a significant reduction of the composite primary endpoint of cardiovascular death, non-fatal MI, and non-fatal stroke. The recommendations of the International Society of Hypertension guidelines go exactly in the same way. For those patients with grade 1 or grade 2, in addition to lifestyle, low-dose combination in the majority of patients is recommended. And similar to the European Society of Hypertension guidelines, only consider monotherapy in low-risk patients or old or very old patients with frailty. How to start treatment? Well, the recommendation is adapt the decision to the global cardiovascular risk. All you know perfectly that the stratification risk of the European guidelines, and you may see that the risk for a given degree of hypertension or blood pressure values depends on the associated cardiovascular risk factors, the presence of hypertension-mediated organ damage, diabetes, or previous clinical cardiovascular disease. The same table is used by the guidelines of the International Society of Hypertension, but it's simpler. They have simplified our table of stratification, eliminated the grade 3 and eliminated the patients at very high risk. You may see that this is simpler, and for a given blood pressure values, for instance, grade 1 hypertension, you may see that low risk or moderate or high risk will depend on the associated cardiovascular risk factors of the present or target organ damage or clinical complications. In this sense, our guidelines recommend in grade 1 hypertension, in addition to lifestyle, if after 6 months, maximum of 6 months of lifestyle advice, blood pressure targets is not achieved, the recommendation is to start treatment. And of course, for any grade of hypertension, immediate drug treatment is recommended when the global cardiovascular risk is high or very high. Which kind of drugs we have to select? Well, the recommendations of the European guidelines are clear. So blockade of the renin-angiotensin system associated with a calcium channel blocker or a diuretic, and only consider monotherapy in these patients at very low risk or old or very old. If these low doses starting treatment are not enough to achieve blood pressure target, the recommendation is maintain one single pill, so fixed dose combination of the 3 components increase the doses and associate the three blockade of the reangiotensin system, calcium channel blocker, or and a diuretic. If this triple combination at maximal doses is not achieving blood pressure target, we go to another entity that is the so-called resistant hypertension. Remember that beta blockers have to be used when clinical indication for their use exists. So, and this means that for any kind of complication of cardiac complications, heart failure, angina, post-MI, atrial fibrillation, etc., a beta blocker have to be used even in the first step. The recommendations of the International Society of Hypertension goes in the same way, because it seems that the initial recommendation is different, but it's not true, that the blockade of the reangiotensin system plus calcium channel blocker is the preferred recommendation to start treatment by the ISH guidelines. However, they consider that a diuretic must be used in specific circumstances, for instance, in post-stroke, in very elderly subjects, incipient heart failure, or intolerance, of course, to calcium channel blockers. And in the Black population, the recommendation is considered the association of calcium channel blocker plus a diuretic. The recommendation is essentially the same, in the same way, going to the resistant hypertension when blood pressure is not achieved using maximal doses of the triple combination in a single pill or fixed dose combination. In summary, all hypertension guidelines recommend to initiate antihypertensive drug treatment with a combination of two antihypertensive drugs of different classes in the vast majority of patients using a single pill combination to improve adherence. Recommendation to initiate antihypertensive drug treatment in monotherapy with a single compound is reserved for patients with low cardiovascular risk and grade 1 hypertension, and for very elderly or frail patients. Why? This recommendation is based on the most recent evidence we have concerning combination therapy, because combination induces a more important blood pressure reduction, what is relevant. In fact, in the rationale for the use of combination therapy, remember that the pathogenic mechanism of hypertension in humans are very complex. At least three main mechanisms may be involved: sympathetic nervous system hyperactivity, the hyperactivity of the renin-angiotensin aldosterone system, and the excess of volume associated with problems with the sodium management and water. So, but the impact of each of these abnormalities may be different in different subjects. So this is the complexity of treating patients with essential hypertension. In fact, you may see a patient one in which the main abnormality is related to the hyperactivity of the sympathetic system. The patient B, which the main abnormality is renin-angiotensin system, or the patient C, that the excess of volume, patient with chronic kidney disease and excess of water. So it's very difficult to know when you treat a patient which is the main mechanism involved in your particular patient. For this reason, when we use antihypertensive drug acting on a single mechanism, we have the chance of normalized blood pressure only when there is a coincidence of the main mechanism involved in these patients and the drug we are using. For this reason, in monotherapy, no more than 40% of subjects may be normalized. However, when you combine different drugs with different mechanism of actions, as this picture shows, you increase the chance of normalizing blood pressure because you are acting on more mechanisms that may be involved in your patient. The meta-analysis of Law many years ago, in 2009, demonstrated that in 147 studies, including close to 500,000 patients, the reduction of systolic blood pressure using monotherapy was able to reduce 24% in coronary artery disease, 33% in stroke, in subjects, for instance, aged between 60 and 69. But in this same population, the use of combination therapy and a further reduction from 10 to 20 millimeters of American systolic blood pressure was able to increase the reduction in coronary heart disease and the reduction in stroke. Even a very recent paper showing that low dose combination of 4 antihypertensive drugs, the quartet study published in Lancet, demonstrate that this combination, imagine you may see 37.5 of irbesartan and ARB, 1.25 of amlodipine, 0.6 of indapamide, and 2.5 of bisoprolol. This combination, very low dose combination of 4 drugs, was able to reduce significantly blood pressure more than any of the monotherapies of each of these drugs at the standard dose. And the quarter study show a significant reduction in the primary endpoint. In addition to the induction of more important blood pressure reduction, also a reduction in the individual side effects. All you know that the use of the hydropyridinic calcium channel blockers, for instance, amlodipine, is a potent vasodilator, and blood pressure reduction is accompanied by an increase in the heart rate, reflex tachycardia. However, when you combine the hydropyridinic calcium channel blocker with a beta blocker, you increase blood pressure reduction by the effect of the beta blocker, but you reduce reflex tachycardia. In the same way, all you know that the calcium channel blockers induce vasodilation in the precapillary arterioles, and this is the reason of the ankle edema, shown by percent between 10 and 30% of patients treated with calcium channel blockers. However, when we combine the calcium channel blocker with a RAS blocker, inducing a simultaneous vasodilatation in the pre and the post-capillary arterioles, there is a reduction in the intracapillary pressure and minimization of the water leakage. So the chance of having ankle edema with the combination is lower than the use of a single calcium channel blocker. Also, the combination improves therapeutic adherence. This is important because the number of pills matters. You may see in this study in 2 populations in Europe, United Kingdom and the Czech Republic, in which patients in which serum and urine samples were used to detect the prescribed medication, you may see that the number of pills are associated with the bad adherence. The higher number of pills, the higher bad adherence, even achieving more than 60–70% of patients treated with more than 6 pills, the adherence is very, very bad. And when you have a patient normalized with a free combination of multiple drugs, for instance, 2 pills of antihypertensive drugs, in these patients, if you put the 2 pills in 1 pill in a single pill combination, you may see in this slide the adherence increases from 42% to 69%. So fixed dose single pill combination increases adherence. And this was explored in the meta-analysis and the systematic review we recently published in hypertension, comparing the adherence in single pill versus free equivalent combination therapy. And summarizing the results, you may see in the slide that in blue color, the medication adherence, the medication persistence increases significantly, about 80% in patients receiving single pill therapy in comparison with patients with free therapy. And also systolic reductions, diastolic reduction, and the achievement of blood pressure target was significantly higher in patients receiving a single pill compared with a free pill combination. And finally, blood pressure control is earlier using combination treatment. In this slide, you may see what happens starting treatment in initial combination in red color or in monotherapy and adding on depending on the blood pressure control. And you may see that after 6 months of treatment, there is already a significant difference in the number of patients reaching blood pressure target. And this is accompanied by a reduction of cardiovascular events. In this same study, you may see what happened with acute MI with coronary artery disease, hospitalization, and cardiovascular death, including all kinds of things. So the majority of events are reduced using combination therapy as a starting therapy. And this is crucial because the reduction of the number of pills and the increase in adherence reduces all-cause mortality, comparing patients with good adherence and patients with poor adherence. You may see that adherence to antihypertensive treatment increases close to 30%, reduces all-cause mortality about 30%. And this is true also in patients, in the elderly, in frail elderly patients. This more recent data from the Lombardy, the study in Lombardy region, in more than 1 million frail elderly individuals, comparing what happened in these patients with good clinical status, poor clinical status, or very poor clinical status. You may see that the comparison of adherence. When we look what happened in these subjects receiving and being adherent more than 76%, between 76 and 100%, you may see a reduction in all-cause mortality in all patients, independently of the clinical status. So even in very poor clinical status, mortality is reduced in patients adherent to treatment. And this very recent data from the meta-analysis of Tomopoulos and co-workers of 93 randomized clinical trials, including more close to 300,000 patients, you may see what happened from the use of one drug to the use of 2 drugs or more. So combination therapy reduces all kinds of cardiovascular events, including all-cause death and cardiovascular death. And however, the increase in adverse effects is not significant. So there are many evidence emphasizing that the use of combination therapy will reduce much better than monotherapy mortality and morbidity in our patients. So to summarize all these messages, the European guidelines and the International Society of Hypertension guidelines, even the World Health Organization guidelines published in 2021, all of them try to send exactly the same message. Start treatment in most patients with 2 drugs, not 1. Initial therapy for the majority of patients with hypertension should be with a combination of 2 drugs, not a single drug. The exception would be in a limited number of patients with a lower baseline blood pressure close to their target, or in frailer or old patients in whom more gentle reduction of blood pressure may be desirable in order to avoid side effects. The most important side effects in the elderly, for sure, is orthostatic hypotension and falls and fractures. And finally, a single pill strategy to treat hypertension is the second very important message. Poor adherence to blood pressure lowering drugs is recognized as a major factor contributing to poor blood pressure control rates. Research showed a direct correlation between the number of pills and poor adherence to medication, and single pill combination therapy improves adherence to treatment. Finally, single pill combination therapy is the preferred strategy for initial 2-drug combination treatment of hypertension in the vast majority of patients. Thank you very much for your attention.